Well, hi, everybody, and welcome to beautiful Cleveland, Ohio. We are so happy to have you here on another one of our live events from the Cleveland Clinic broadcast. So just going to have a wonderful evening with panelists talking about anorectal disease, evaluation and management. Next slide. So I just want to start off with saying a huge thank you to the nearly 1,300 healthcare providers who have registered from over 100 countries here, and both via live as well as watching this on delay at a later time. Thank you so much for taking time out of your morning, evening, or sometimes late nights to join us here from Cleveland Clinic. Next slide. Now, we want this to be as interactive as possible. So we highly encourage, as Steve said, for all of you to please utilize the chat box. We will be looking at that. We'll each go back when we're done and see if there's any questions that we didn't answer. So please put and encourage you as much as possible to put in any comments, questions, anything that's unclear. And we'd like to thank our corpus industry sponsors for their generosity in providing the grants for our 2024 series. We absolutely could not hold any of these CME offerings without our industry sponsors, and we're most grateful for the support of them. And you can see here, Cook Medical, Janssen Biotech, Medtronic, and Olympus Corporation of the Americas. Just a giant thank you to them. Next slide. It is my absolute pleasure to introduce tonight's faculty. First, the true activity director behind is Dr. Kristen Ban, who is one of our staff here at the Cleveland Clinic, and she's an assistant professor of surgery at Lerner. She's going to be guiding you through tonight's evening. Next is Dr. Ariel Canters, who is our associate program director for our colorectal surgery residency. And then finally, AJ Keschenrow, who's also one of our staff from the Department of Colorectal Surgery and also an assistant professor of surgery at Cleveland Clinic Lerner College of Medicine. And with that, I'm going to turn it over to our true host, Dr. Kristen Ban. Kristen, take it away.
Thank you, Dr. Steele. I want to welcome everyone. Thank you for joining us. And we're going to jump right into our first topic with Dr. Keschenrow, who's going to be discussing hemorrhoids.
Good evening, everyone. Thank you for that introduction, Dr. Ban. As Dr. Ban mentioned, I am going to be talking about hemorrhoids. As some of you are aware, most patients come to see us for hemorrhoids, so it's pretty common. So I'm going to go through some of the basics. I have no disclosures. In terms of objectives, I'm going to be talking about what are hemorrhoids, what are important in clinical evaluation, treatment options, and then some special considerations. So hemorrhoids are arteriovenous tissue in the submucosal layer of the anal canal, so they act as an anal cushion. It's pretty physiological. It augments the closure of the anal canal in response to increased abdominal pressure. So it does have some baseline continence, fecal continence for patients. So it can give you up to 20% of rested anal canal pressure. In terms of external versus internal hemorrhoids, you want to look, it's in comparison to the dentate line, but it can also communicate, so you can have some patients with mixed component. When it's external, it's below the dentate line, and this has some consequence because that has a somatic innervation, so it can lead to pain in some of the symptoms. Once the internal is above dentate line and has visceral innervation, which is more for pressure, and there's 3 columns along the anal canal, so you have the left lateral, right anterior, and right posterior. So when it becomes pathologic, you can end up with a picture to the right. You can see some swollen tissues on the inside. And as I mentioned, it's pretty common anorectal disorder. Prevalence could be as high as 12.8% in adults, and this is globally. The risk factor are multifactorial. We have straining, which can increase intra-abdominal pressure, elevated anal pressure, and then patients not eating adequate fiber. Symptoms can vary depending on whether it's external or internal. External could cause pain, itching, difficulty with hygiene, whereas internal can cause painless red blood per rectum, especially with defecation, and it can also prolapse if it gets enlarged enough. In more acute presentation, patients can have thrombosis of the external hemorrhoid. With a picture seen to the right, you can see it will feel like a hard marble, and this can sometimes be unroofed in the clinic and get the clot out to provide symptomatic relief. And then patient can also have prolapse strangulated hemorrhoids, which is more of an urgent surgical intervention. But it is important to make sure this is not a rectal prolapse. This picture is a little less convincing, but sometimes it's very important to make sure it's not a rectal prolapse. Clinical evaluation, very important. You want to get a thorough history, assess risk factors such as constipation and straining. And with constipation, you want to assess bowel movement consistency, how long they're spending on the commode. if they're taking any bowel regimen, and then also ask about prior intervention because that can have implications on what kind of interventions you offer. And also it's very important to ask about abdominal symptoms because sometimes this could be an initial presentation of IBD or cancer. So you want to ask about abdominal pain, progressive constipation or new onset constipation, any nausea, vomiting, and weight loss. And then for physical exam, you can do it in lateral decubitus or point jackknife. My preference is the latter. External exam, you want to see if there's anything on the outside. I also have patient Valsalva, see if anything prolapse, do a digital rectal exam, and then endoscopy, which helps you get more of a better look inside. And it's also important to make sure patients are up to date on the colonoscopy, especially those that are due for it or those with high risk based on family history. And then those patients that you see without the obvious source of anorectal bleeding on an exam, it's very important to do for the evaluation with colonoscopy. And this is just a quick picture of the internal hemorrhoid grading system. So grade 1, it's enlarged, still above the dentate line. 2, it is more enlarged below the dentate line and can prolapse out with Valsalva or defecation, but this usually spontaneously reduced. And then 3 requires manual reduction, and then 4 usually is non-reducible. So when we talk about treatment, we tend to talk about conservative management as first line, but it's very important that patient understands regardless of whether they need intervention or not. This is very important. This is the basis of treatment, and it's very important they have this down. So make sure they get adequate fiber and drink adequate water. This can make sure that they have a good consistency stool and improves bleeding and even some mild to moderate prolapse, as well as their behavior on the toilet. So again, straining, time on the commode. They should not be straining. They shouldn't spend long on the toilet because regardless of what you do, if they're doing those things, the hemorrhage will come back. And then I put the over-the-counter therapy on the first line, but it's not mandatory. This are just things that can provide symptomatic relief with minimal harm, but should avoid prolonged, patients should avoid prolonged use, especially with the hydrocortisone. And then in terms of the intervention, it could be office-based or surgery. With office-based, we have things like bandage, sclerotherapy, infrared coagulation. Where surgery, we have hemorrhoidectomy, Doppler-guided hemorrhoidal artery ligation, and then stapled hemorrhoidoplex. I'm going to start with the office-based procedure. With the band-in, the band is placed proximal to the dentate line, which strangulates the hemorrhoidal column and also fixes the mucosa to submucosa. And after about a week, the band tends to slough off the hemorrhoidal mucosa, leaving behind the ulcer. And the ulcer is more important for especially patients with anticoagulation because that's when they can actually bleed. It's considered the most effective office-based procedure and can be used for a lot of the hemorrhoids grade 1 to 2 and also selective grade 3. Complication, pain, especially if the band is put below the dentate line. Bleeding, as I mentioned, you can also get perianal sepsis. And this is just a quick picture of some of the equipment. Make sure you have a good anoscope that has adequate width and length. And this is the one I use in my office. It's lighted, so that also provides better visualization. And then for the ligator, there's usually 2 bends at the top of it. This is connected to a suction, so this is a suction ligator. And then I always ask patients if they have pain before I apply the bands. Injection sclerotherapy, you're injecting sclerosing agent into the submucosal layer, which causes inflammation and fibrosis of the tissue and also scarring. So there's various agents, but I tend to use the 5% phenol and almond oil, and there's also hypertonic saline. You put about 1 cc into each column at the base of the hemorrhoid. You do want to avoid injecting below the dentate line because that actually can be quite corrosive and cause some wound issues. It's relatively safe in patients with anticoagulation, and that's kind of where I've preferred using it. Some complication, pain, abscess, especially if injected too deep, low incidence of bleeding, and then they can get recurrence ranging from 1.5 to 29%. And then infrared coagulation is of the similar principle as the sclerotherapy, which is basically using energy instead of injection to cause sclerosis of the hemorrhoidal tissue, and again can be used for grade 1 and 2, and you can treat multiple columns at once. It has similar efficacy to rubber band ligation. In terms of surgery, I'm going to start off with the gold standards, which is the hemorrhoidectomy. You excise the hemorrhoidal plexus, the apex. You want to make sure you don't damage the underlying internal sphincter muscle. And then the wound can be left open, which is your Milligan-Morgan, or it can be closed, which is your Ferguson approach. But the Ferguson is associated with faster healing and reduced post-op bleeding. One of the biggest things that you have to talk to the patient about preoperatively is how much pain they will have, and they always still underestimate it. So it's very important to have that manage the expectation preoperatively. I tend to just use hemorrhoidectomy for symptomatic external hemorrhoids or patients with hemorrhoids with mixed component, because I think for those, you can't really use the other treatments. Complication, you can have acute urinary retention, bleeding, anal stenosis, especially if you take too much Enoderm. And this happens more in the acute setting when you're doing an urgent hemorrhoidectomy. And then fecal incontinence, that tends to happen if you damage too much the sphincter muscle, and then perianal sepsis. You have a picture to the left and the right. The one on the left is showing the Milligan-Morgan, in which after the tissue is excised, is left open, and then the Ferguson with the defect is closed. Here's some things that are important that I use. I make sure the patient gets pre-op enemas. I don't use antibiotic. I use monitored anesthesia care, so that's MAC anesthesia with pudendal block. I tend to use the liposomal bupivacaine, so that's Exparel, because it gives prolonged analgesia. So for like 2 to 3 days, patients usually say they're pretty comfortable first before then the pain kicks in. I tend to do it in point jackknife just for better visualization and teaching. And then after I suture ligate the pedicle with an absorbable suture, I use the same suture to close the defect in a lock-in fashion. And I leave a few millimeters of the enoderm open so that it can provide better drainage. And in my personal preference for energy device is the needle tip cautery. There's been multiple studies looking at the different energy device, and I think there was only one study that showed bipolar does provide less pain, but otherwise most of the studies are not really supporting one energy device over the other. With Doppler guided hemorrhoidal artery ligation, you use the Doppler to pinpoint the branch of the hemorrhoidal artery, and then you suture ligate this, and then you can do with or without doing a mecopexy. So I tend to do it with mecopexy. And then this can be used for grade 2 to 4 internal hemorrhoids. The only thing is that with the higher grade hemorrhoids, the increase of recurrence is higher. With grade 4, it can be as high as 18%. But in about 95% of patients, you get resolution of bleeding and prolapse, which is great. Less pain, faster recovery. And again, because this spares the enoderm, so you're not making any incision on the enoderm, that's kind of why probably they have less pain compared to hemorrhoidectomy. This can be repeated, and then complication includes tenesmus, pain, bleeding, and anal fissure. This is just a quick picture. So this is the THD, the transanal hemorrhoidal dearterialization. So for this, you can see the Doppler at the top of the anoscope. This is usually a lighted one that comes together with the device. So the Doppler then is right up against the vessel, so you can catch the signal, and then you put through the pivot, you put your suture, usually a figure of 8. I usually pull up on that and check if there's a loss of signal. And if there is, I take out the Doppler, and then I tie it down, and then I subsequently do my mecopexy. And you want to stay above the anorectal junction, and usually do it at 6 different points. And this is a quick study from 2013. It was a multi-center prospective study with multiple surgeons, so 20 surgeons, 197 patients, and this was comparing THD to Ferguson hemorrhoidectomy. So they found that patient had lower visual pain score, post-op day 1, 7, and 14. Also, less pain meds were used at post-op day 14. And then here's a graph showing patient satisfaction at 14 days and 3 months was significantly higher with the THD compared to hemorrhoidectomy, but no difference at 6 months or 1 year. And there was also no difference in recurrence. So THD is a pretty good option to offer patients. And then I just put stapled hemorrhoidopexy because it is still being used, but it's kind of fallen out of favor because of its risk profile. So it's basically using a circular stapler, which is the shown over here. I haven't used this since training. I haven't used it in my own practice, but you use a circular stapler to excise the submucosa proximal to the dentate line, and that includes the hemorrhoidal plexus. And then you also fix, that allows cephalad fixation of the anal cushion. So here's just a quick picture showing how this works. So there's a suture placed above the plexus that gets pulled into the stapler, then you close it, you hit it with anastomosis. The problem with this is it has a higher risk of recurrence of hemorrhoid compared to a traditional hemorrhoidectomy, so odd ratio of 3.2. And then it's also associated with higher risk of post-op bleeding and prolapse recurrence. Patients are also more likely to require additional operative procedure. And then in terms of the reason why it's probably falling out of favor is because of the risk profile. There's been reports of rectovaginal fistulas, deep line bleed, strictures, and rectal perforation. So in terms of post-op management, very important to have multimodal pain control. So I usually have patients on scheduled Tylenol, NSAIDs, and then with some PRN narcotics for breakthrough. And then obviously with the narcotics, or even in general, they can get very constipated. So I have them on an aggressive bowel regimen, and then I tell them sitz baths is pretty helpful for controlling their symptoms as well. And I make sure I don't see them for the first 4 weeks because they're pretty miserable at that point. And then finally, special consideration. So patients on antiplatelets, I think for most of the approach, you don't need to hold it. maybe for the hemorrhoidectomy, I would personally hold it, but no, there's no big difference in bleeding based on most of the data. In terms of anticoagulation, again, it depends on how long they can hold it for, if they can hold it for, and how long they can hold it for. If a patient can hold it, I think sclerotherapy is a pretty good option at that point. If they can hold it, THD is a good one. Or, even banding in the office if you don't want to do a surgical procedure. For pregnancy, patients tend to get really bad hemorrhoids, but it usually resolves after delivery. So surgery is usually reserved for the ones with strangulated hemorrhoids. And then if they're coming with TEH, I usually take care of that in the office. And then for portal hypertension, it's very important to differentiate between hemorrhoids versus rectal varices. If it is varices, you have to address the portal hypertension first. And then finally, just my last slide, just some key takeaways. So it's a pretty common benign anorectal condition. So, but be very thorough with your history and exam, and any red flags should lead to further evaluation, especially with the rise of young onset colorectal cancer. Fiber and water toilet habits are very mandatory for all type of hemorrhoids, so it's very crucial to have that education with the patient. And then there's different procedures in the office and surgeries that we can do. And if you do proceed with surgery, it's very important to do preoperative counseling with the patient to manage the expectations. And that is everything I have for you. Thank you.
Thank you for an amazingly efficient, high-yield review of a topic that could have taken a lot longer. I already see some questions in the comment box. We're going to run through questions for all of our speakers during the Q&A and panel section. So keep putting questions in there as you think of them. We're going to transition next to Dr. Cantors, who's going to be discussing anal fistula.
All right, so thank you everyone for the opportunity to talk about anal fistulas. First and foremost, I'll just kind of start by saying there is no such thing as a straightforward fistula. And this talk, though only about 12 minutes long, is a very, very superficial overview. The simple fact is I think we all need to cut ourselves a little slack, and those of us who treat perianal disease, and particularly in terms of fistulas, and just know that this is not easy. It's challenging for patients, it's challenging for providers. So before we start actually talking about management, it's important to think about the anatomy, because fistulas will begin as abscesses. And so to understand where the abscess is essential in determining how you can best manage it and try to minimize consequences in that management process. So thinking about the perianal space, so distal or lateral to the sphincter complex, the deep postanal space, which is lateral to the sphincter complex, but deep to the anococcygeal ligament. This will be particularly important talking about horseshoe abscesses, and then any abscesses related to the levator, so the supralevator space. And this anatomy is also relevant when we talk about our Parks classification, which is how we try to think about the types of fistulas we're dealing with. And for the purpose of this talk, I forgot to mention, I apologize, I'll be focusing on fistula and ano. I will not be talking about Crohn's-related fistulae or rectovaginal fistula, so more of a cryptoglandular pathology. So first you have a type 1 pathology, which is intersphincteric, so just involving the internal sphincter. You can have a type 2 pathology, which is a transsphincteric. A type 3 pathology, which is a suprasphincteric, so traveling in the intersphincteric groove up and over essentially the external sphincter complex. Or you could even have an extrasphincteric, which is a much more complicated tract, because it actually begins more in the rectum than in the anal canal. And importantly, we must think about what amount of the sphincter complex is involved, because when it comes time to drain these abscesses, if it's a truly intersphincteric abscess, it can actually be drained in the intersphincteric space versus in the anal canal. If it's a transsphincteric, we need to think about how close are we to the skin versus trying to drain transanally again. And then when we start dealing with the more complex external sphincter involvement, for example, a suprasphincteric or extrasphincteric, we're not necessarily if we're worried about long-term management, we're very much thinking about let's get control of the situation rather than trying to treat it at first go. So abscesses themselves, especially cryptoglandular, are thought to form from obstruction of the anal canal. These abscesses will form, and then approximately 50% of patients will go on to actually form a fistula tract, which is epithelialization of that abscess canal. And importantly, whenever I'm draining someone with an abscess for the first time, I reinforce this with them. If it comes back, that's not a failure of management. That's the simple fact that we can flip a coin, and this may become a chronic process for a lot of patients. When it comes to actually managing the abscess and ultimately the fistula, I try to think about it these four things. These are my four goals. One, I need to eliminate the sepsis. So when I'm first seeing a patient, it is not about definitive management. It's about let's get control of the situation. And once we get control of the situation, then we can figure out how are we actually going to close the fistula tract. Then once in the process of figuring out how we're going to close the fistula tract, I need to think about what am I going to do in order to preserve the patient's fecal continence and sphincter function. Importantly, when the first time you're taking a patient to the operating room, if there is no obvious tract, that's okay. We want to drain the abscess and then allow the inflammatory process to settle in order to eventually find the true tract. And if that requires placing a mushroom or a Malacot drain just to prevent premature closure, that's appropriate. You do not need to expect to get a ceton in at first go. Then finally, when it comes time to actually do the procedure, and again, in deciding the procedure, you want to minimize the chance of recurrence. I want to encourage everyone to check out the clinical practice guidelines as presented by the ASCRS group, and there's specifically one available on anorectal abscesses, fistula and ano, and rectal vaginal fistulas. So in managing a patient, this is typically outside the setting of an emergency room, but when a patient comes to my clinic, first and foremost, physical exam. I'm looking for external openings or fluctuant areas, evidence of a persistent tract. And sometimes the patient is too tender and they're not able to tolerate this, in which case taking them to the operating room may be necessary. But if possible, I'll try to get a sense of their sphincter function. I'll check the pelvic floor function and I'll get a sense of sphincter length. Because once they're asleep in the operating room, it'll oftentimes feel a lot shorter and a lot more challenging to understand how much is involved in the tract. Again, if they cannot tolerate it in the clinic, then an exam under anesthesia is absolutely appropriate and is likely going to be required regardless. In terms of imaging, the CT abdomen and pelvis is a good option if trying to look for things like abscesses. However, if you're looking for more of a complex fistula tract or an unidentified tract, then an MRI pelvis is going to be more appropriate. And speaking with the radiologist who's protocoling it can be beneficial in order to ensure they're doing the appropriate protocol. Endoanal ultrasound is very user dependent. I do not typically use this, but it can be used in the operating room with, for example, peroxide enhancement in the setting of not being able to find the tract otherwise. When it comes to management, the simple fistulotomy is the goal. A fistulotomy, the actual laying open of the fistula tract, is only an option though for simple fistulae. So intersphincteric, so only involving the internal ring. Low transsphincteric, so involving the typical teaching is less than 1/3 of the external anal sphincter, thereby minimizing the chance of incontinence. And then the reason this is the gold standard is it's the one that's got the best outcome. So approximately 90% successful resolution of the fistula. In doing this, what we do, we'll typically place a lacrimal duct probe through the tract, excise the overlying skin and come down to the muscle. This picture makes it look like we're taking a lot of muscle. That is not the goal. Once the tract has been open, we'll oftentimes marsupialize the edges, so actually tack them down. And the goal is to help minimize the chance of the tract reforming by early skin healing. In terms of antibiotic use, I limit this to patients who are high risk. So if there's evidence of cellulitis, of more of a local reaction, then that would be an appropriate use of antibiotics. Otherwise, signs of sepsis or systemic disease, or those who are immunosuppressed, for example, patients on chronic steroids, transplant medication, or in the diabetic patient population. Draining cetons can also be a very, very valuable tool, particularly when trying to get damage control. So placing a silastic vessel loop at the time of drainage or once you're trying to mature the tract can help prevent recurrent abscess formation and keep the fistula tract open. These are safe. The patients can live with these, particularly in our Crohn's patient population, and they are particularly important in the patients who are not candidates for fistulotomy right up front. So the high transsphincteric, the suprasphincteric fistula and anterior fistula in women, and particularly those who may have had undergone childbirth in their past, or in the Crohn's patient population. How you choose them is how you tie them is totally up to you. The color you choose is also dealer's choice. I typically try to tie them in line. Patients find it less bothersome. And then when actually draining the abscess, it's very important to keep in mind things like a horseshoe fistula. So in a CT scan is obtained preoperatively and it has this horseshoe anatomy, it's important to keep in mind the possibility of it being a deep postanal space infection, because abscesses that are deep to this anococcygeal ligament can actually track in both directions around the anus, along the ischioanal fat process. So draining just in the middle is not going to actually give you, or draining just the perianal abscess is not going to get you control of the infection. You'll ultimately end up back in the operating room. And so if you are dealing with a horseshoe abscess, it's important to actually get into the deep postanal space by incising the anococcygeal ligament. And typically we talk about a modified Hanley approach when we're draining up a horseshoe abscess, which involves drainage of the deep postanal space from the internal, it's usually a posterior midline internal opening. So internal opening to the posterior midline, and then placing also 2 lateral drains, Penrose drains or Seton drains, in order to get full control. These lateral drains can be removed in clinic once the abscess cavity has collapsed. And then eventually what that will leave you with is a posterior midline fistula tract, which can then be managed however you ultimately need. Additional management options, and this is what we'll talk about next. So cutting setons. I feel like when I was early in residency was told this is totally barbaric, but we're actually seeing this come back in favor because of the success and the opportunity to convert a high fistula or a complex fistula to a low fistula that can be turned into a fistula that can be treated with a fistulotomy. What it does is allow for gradual obliteration of the tract and basically filling in of that proximal more proximal sphincter defect with scar tissue. A mucosal advancement flap is another good option, particularly in the setting of a failed previous repair. A lift procedure is an option for a sphincter preserving approach and is a good first line defense for a well matured tract. And then briefly we can talk about fistula plugs, glue, and then video vacuums and lasers we will not be going over today. So a cutting seton, typically taught as a silk suture, but many of us will use a tightly placed silastic vessel loop because it's more comfortable. What it allows is slow transection of the external sphincter due to pressure necrosis, and this stimulates fibrosis. And then as the fibrosis fixes, it prevents retraction and separation of the muscle. So again, conversion of a high to a low transsphincteric tract. It's important to incise the overlying skin so that you actually get a full circumferential and pressure necrosis. The traditional teaching is that you take them back to clinic and treat the tract by tightening it about every 2 weeks. More recently, I'll have patients pull on their seton at home, and that stimulates a similar reaction. And here you can see how you have a fibrotic replacement of the sphincter defect. A lift procedure is a sphincter preserving approach where you actually transect the tract in the inner sphincteric groove. Initially, the data suggested a really high rate of successful treatment, including up to 90%, and more recent meta-analyses show closer to about a 75%. This does require a mature tract, so a seton must be in place before this is attempted. Risk factors for failure include things like a horseshoe anatomy, so a deep postanal space infection, Crohn's disease, or multiple previous attempts that have failed. So in this situation, once the tract is well matured, as you can see by this residual fibrotic tract, it's isolated in the intersphincteric groove, and then suture ligated and then transected. And the tract also must be curetted in order to induce fibrosis of any residual opening. Mucosal advancement flap is typically my preferred approach. And oftentimes when I see a patient coming to me, they may have failed a previous attempt, and that's why we settle on a mucosal advancement flap. So again, it's important to curette the tract itself. This has to be a relatively mature tract. You do not want any residual cavities, either hypergranulation or abscess cavities in the perianal or ischiorectal space, as this will potentially break down the mucosal flap. And the goal is to cover the internal opening with a mobilized segment of rectum or anal mucosa. The success depends on how many failed attempts, scar tissue, et cetera. And risk factors for failure include malignancy, history of radiation, Crohn's disease, and more complex tracts like a rectovaginal fistula. So in this situation, we are isolating again out the tract and creating a partial or full thickness tissue flap, proximal, mostly proximal to the defect, as well as some amount distally. The flap is fully mobilized, traditionally in a 2-to-1 ratio, so twice as wide it is long in order to minimize the chance of necrosis. The internal tract itself is closed, particularly in the setting of a transsphincteric defect. And I do this just interrupted figure of 8 2ovicrals. You excise the actual internal opening, and then you bring down the tissue flap and secure it in place. Fistula plugs and glues are not very effective. The clinical practice guidelines specifically state they're relatively ineffective, and I do not recommend these. So key takeaways I think about. So number one, and I should have emphasized this earlier, you have to set realistic expectations for patients, just like when you see them for the first time in the emergency department, when you're draining the abscess, 50% of these will probably come back as some form of a fistula. When they come into your office with a fistula, you have to say, this is not going to be a one and done. This may be a 6-month, 1-year-long procedure or process with multiple trips to the operating room to have success. And great, if you get it done in one fell swoop, fantastic, you look like a hero. But if it does take that long time, or you have to refer out due to continued recurrence or persistence, then realistic expectations are set from the beginning. Additionally, control the sepsis until the sepsis is controlled and the hypergranulation inflammatory process is controlled. It will be very difficult to have any successful management of the tract. And then if you're dealing with a complex fistula, do what you can, cutting setons, et cetera, partial fistulotomy, so staged approaches to convert it from a complex fistula to a simple fistula. And then importantly, always prioritize, maintenance of continence. So doing whatever is possible to minimize injury to the sphincter complex. Thank you.
Thank you so much, Dr. Canters. And already I see great questions in the comment box. Keep them coming. I'm going to share my screen and we'll cover our final topic, which is anorectal red flags. So we're going to discuss red flags specifically for inflammatory bowel disease, high-risk HPV lesions, and then also for malignancy. And we'll discuss the workup. And I also want to take time to go over how to deliver unexpected news. So it's always hemorrhoids. Patients are always going to come in and think that that's what's going on. And what's challenging is that you commonly have overlap between normal and red flag symptoms. Pain, bleeding, change in bowel habits, those things could be due to a benign process, but they could also be associated with something more insidious. Weight loss, if they're way overdue for colorectal cancer screening, medical neglect, or strong family history, those are things that should kind of capture your attention from the get-go. And typically what happens is you perform a physical exam, you have findings that are concerning to you, at which point it is totally okay and appropriate to obtain additional history. So for an inflammatory bowel disease, HPI, some of the red flags might be a change in bowel habits that is specifically kind of new frequent diarrhea. They may have blood in the stool. And when you go back, they may endorse some abdominal obstructive symptoms, recurrent symptoms, and non-healing wounds after prioanorectal procedures are other things to capture your attention. Weight loss, a family history of IBD, and then also skin lesions or some of the extraintestinal manifestations can be a clue that there's an IBD diagnosis underlying their anorectal pathology. So on physical exam, when you're doing an external exam, these are some examples of some findings that would point to an IBD diagnosis. So the elephant ear skin tags, where you have really prominent external hemorrhoid tissue, anal fissures that are off midline, complex anal fistulas, whether multiple tracts, suspected trans, supra, or extrasphincteric anatomy, or associated ulceration or granulation tissue, whether with the external opening or subsequently on anoscopy. On your anoscopy, or if you have access to endoscopy in an office setting, you may see candidate internal openings, multiple for complex fistulas. You may see atypical anal fissure locations better with this exam. And you may also see proctitis, where you actually have inflammation of the distal rectal mucosa, as well as inflammatory mucosal lesions. So this is when you're going to go back to query some of those other elements of the HPI, like abdominal symptoms, if you were previously focused on an anorectal chief complaint, and again, some of the extraintestinal manifestations. In terms of your workup, this is definitely a point where you want to hit the pause button. Of course, you're going to control sepsis, but you would probably be starting with a colonoscopy, random biopsies of the colonic mucosa, including the TI, and then consideration of enterography, whether CT or MR. And if you have a complex fistula, MR of the perineum or pelvis can be very helpful. If you're going to initiate this workup on your own before referring them to GI, labs including a CBC, CMP, CRP, sed rate, and fecal calpro can be helpful. And if your index of suspicion is very, very high, you may just want to refer them to GI if it's going to take a while to get them plugged in. But of course, you're going to prioritize controlling the infection, managing symptoms as best you can, and you're going to avoid surgical intervention until this workup is complete. Transitioning to high-risk HPV lesions, if you know coming in that you're worried about that, of course, you're going to ask about known HPV exposure. In a female patient, have they had an abnormal PAP, prior history of sexually transmitted infection? Have they had HIV testing in the past? And if they know already that they've had prior HPV lesions, you want to get specifics of their pathology. Did they undergo any treatment, and the date since their last anorectal evaluation? On physical exam, some findings will include hypopigmented flat or polypoid lesions. You want to get a really good exam of the anoderm, the anal canal, as well as the distal rectum. And of course, ulceration, pain with palpation are going to raise red flags with concern for underlying malignancy. We'll get into that a little bit more subsequently in the presentation. Your workup could include a few different things depending on what materials you have access to in a clinic setting. You can do an anal pap to look for abnormal cells. If you have a high enough index of suspicion that you want to take biopsies, a rectal exam under anesthesia is usually your best bet, because you can both biopsy visible lesions, but also perform concurrent high-resolution anoscopy, where you're applying a 3% acetic acid solution for 2 minutes, which can reveal occult lesions. Standard, once you've established an HPV lesion, you want to obtain HIV testing to confirm whether that patient falls into the low or high risk surveillance category. And in a female patient, you want to ensure they're plugged in with GYN for surveillance. With regard to vaccination, I have a lot of patients who ask questions about this. There are no current guidelines. At least in the United States, the Gardasil vaccine is approved in all patients to age 45, and so insurance should cover it. There are data in the GYN literature supporting HPV vaccination to reduce recurrence after treatment of a cervical high-grade lesion with an odds ratio of 0.2 and a 95% confidence interval of 0.1 to 0.7. And just of note, there are 2 vaccines available. One is bivalent with a schedule of 0, 1, and 6 months, and the other is a quadrivalent vaccine. This is probably more commonly available in the United States, and that's given at 0, 2, and 6 months. I tell patients, aside from that, insurance may not cover it, but we don't know of any harm. And so the thought process is it may help kind of sensitize the body to kind of attack cells on its own where HPV is active, and to prevent maybe new lesions from cropping up. In terms of treatment, we do have an article out of the New England Journal to help guide management in high-risk populations. So this was a randomized trial looking at adults with anal HSIL who were HIV positive. and they looked at treatment versus active surveillance, where active surveillance was high-resolution anoscopy every 6 months, and treatment was either ablation, excision, or a topical agent, whether fluorouracil or imiquimod. And their primary outcome was progression to anal squamous cell carcinoma. So no doubt about it, in this population, there's a lower rate of progression to squamous cell carcinoma with treatment by 57% at 26 months. So some special considerations in this population. There is very real stigma associated with sexually transmitted infections. And so try to normalize this diagnosis given how prevalent HPV exposure and prevalence is in the population. Preempt that this diagnosis does not mean their partner has been unfaithful. A lot of patients assume that this is a new exposure recently and that points to infidelity in a spouse or partner. So it's very helpful to provide background that the exposure could have been a long, long time ago. We don't always know why these prior exposures lead to new cell changes later in life. And it's helpful, I think, to frame this as a health screening and surveillance type of issue to prevent cancer, because especially in a female population, the concept of doing pap smears is very familiar, and there's no stigma associated with that. So with regard to anal squamous cell cancer, you're going to go back and query all of the HPI elements that are related to HPV, plus your HPI and physical exam elements are going to also cover invasive malignancy, which we're going to discuss next. So some red flags include like a change in stool caliber, tenesmus, obstructive symptoms, weight loss, strong family history of colorectal cancer, no prior colonoscopy, and of course, pain and bleeding. So really your physical exam it's very important that if you encounter something unexpected that you really slow down and take your time, especially on the DRE and with anoscopy. You're going to want to note on your rectal exam, is the mass firm? Is it nodular? Is it fixed? And specifically, is it tethered to the sphincter complex, the pelvic floor, or the coccyx? Pain with palpation can be a warning that this is a more locally advanced process. And then on anoscopy, you're going to see a fungating mass, partially or fully circumferential. It's not going to be associated with the standard hemorrhoid bundle anatomy. You might note that it's bleeding. You might note associated ulceration. And so it's important to really capture all of these exam findings. Additional exam components you might want to add if you have access to these pieces of equipment in clinic would be rigid proctoscopy and flex sig. If you have the ability, you can even obtain consent from the patient to biopsy the lesion in the office if you feel that that's safe. If you're evaluating an anterior lesion in a female, you definitely want to change to a clean glove and perform a vaginal exam to assess vaginal wall involvement. And of course, maybe backtrack at that point to include an abdominal and lymph node exam. With suspected malignancy, if they haven't, they need a colonoscopy and biopsies for adenocarcinoma, and then rectal and vaginal exams under anesthesia if you suspect more of a squamous etiology. And biopsy-proven malignancy will then dictate further staging workup. So final tips, we've talked about how your history might not initially have red flags, but once your physical exam clues you into something atypical, backtrack and get additional information, perform additional exam elements as indicated, and then be very detailed in your documentation of the physical exam. For IBD, you're going to want to note the location, size, character of various lesions, because that's helpful to monitor response to medical management over time. And with malignancy, this is your initial exam potentially of proximal and distal extent of the tumor, the size, invasion of important adjacent structures, and if you can, for an external lesion, a HIPAA compliant photo in the medical record is worth 1,000 words. A final note, how to deliver unexpected news. Patients often come in alone, they think they have hemorrhoids, and now you're concerned about something wholly outside of what they thought they were going to be discussing. Be transparent about your concern, but also be clear that you don't know. Communicate the purpose of whatever additional recommended testing is to confirm or rule out the diagnosis of concern, and acknowledge in the moment the emotional impact of that unexpected news. Ask if there's somebody else that they want you to talk to get on the phone, or if there was somebody in the waiting room who didn't come in with them. And then pause, give them time to process the unexpected information you've just given them and to ask questions. So as an example, you might say, Ms. Smith, I'm concerned that this is not hemorrhoids. I'm worried that the mass I felt and visualized on exam could be a cancer, but I do not know for sure. I would like to schedule you as soon as possible for a colonoscopy. The purpose of this exam is to obtain biopsies to confirm or rule out this diagnosis. I'm sure this is overwhelming and you're here alone. Is there somebody else I can call to discuss my concerns and the recommended next steps? So with that, we're going to transition to our Q&A and panel discussion. Let me pull up our chat so we'll get everyone back on. And let me just get the chat box. All right, so we've definitely got some questions going back to Dr. Kishinro's talk. So what is your preferred management of bleeding internal hemorrhoids that have failed conservative management in the following patient populations? Cirrhosis and those on critically needed anticoagulation who need to get back on that anticoagulation as soon as possible.
Sclerotherapy for both. Yeah, I think THD could be an option for the second patient that needs to get an anticoagulation. Just sometimes they can still have some bleeding issue with those sutures, especially if you can do the ligation without the mucopexy in that situation. I think, but with the mucopexy, there's always a chance of a bit of ulceration that can bleed afterwards. So, but my preferred approach would be sclerotherapy for both.
Great. And
Also
then
just-
oh, go ahead, Dr. Canters.
Sorry, the only other thing I would say, just in terms of to go off of Dr. Band's point though about like the red flags, portal hypertension contributing in any way to that, whether or not tips would necessarily be warranted, just as a very quick side comment. And I actually like THD for the second scenario.
Yeah, I agree with that. What criteria do you use to perform surgery for hemorrhoids versus medical management?
Yeah, I mean, I make sure all patients are doing what needs to be done, what we consider medical management, regardless of what grade they are. But then it depends on what grade they are and how symptomatic they are. So, for example, if I'm seeing a patient with grade 2, grade 3 hemorrhoids and they're on the toilet for an hour, that's gotta be addressed. I am not doing a surgical approach, definitely, without you addressing that. I can do an office procedure like a band-in in those situations, but that has to be addressed before I do any kind of surgical intervention. So I think all patients, I tell them, the hemorrhoids will come back with surgery if you don't do the work, which is fiber, not straining, nice soft bowel movement. So I guess if a patient is already on medical management and they're still having problems with the hemorrhoids, then at that point I would definitely be a little more aggressive about intervention.
And this is kind of advanced, but if they're doing everything and they've kind of exhausted over-the-counter measures and you still don't feel like there's good control, that's an opportunity to say there's something else going on here. We need to get you plugged in with GI. If you suspect pelvic floor dysfunction with non-relaxation, maybe you're explaining that concept and discussing the role of manometry in pelvic floor PT. And I think, again, just impressing upon them, why would I put you through a potentially very painful procedure and recovery if you're going to be right back where you started? And that's very helpful, especially I think for patients who have failed prior hemorrhoid interventions. Those patients are usually pretty open to having a more comprehensive approach before they go down the path of another surgery.
Yeah, I agree with that.
Dr. Canters, does everyone with a fistula require evaluation for Crohn's?
I I think in my practice, yeah, but no, not generally speaking. And I have a whole spiel I give patients about kind of the 3 different types of primary fistulas I see. So cryptoglandular, inflammatory, or traumatic. Those are most fistulas can fall into one of those 3 categories. So if you have a very classic appearing perianal abscess that follows Goodsall's rule, or a benign appearing anus, you kind of look for the other signs that might point you to thinking Crohn's would be involved. An inability to get the fistula to heal, large, elephant ear skin tags, or atypical fissuring pattern, or evidence of proctitis. Most patients, or not most, they will all get an anoscopy either in the operating room or in clinic as part of my initial evaluation. And so looking for evidence of proctitis or anal canal inflammation, those would be the indications that something else needs to be done. If I can't get a fistula to heal, or it's behaving in a complex way, then I'll take them down more of a Crohn's workup pathway. Or if they're 45 years old and need a screening colonoscopy anyway, I'm going to make sure to intubate the TI when I'm doing their screening colonoscopy.
Yeah, is it safe to say recurrent fistula, they've bought themselves a more comprehensive workup before you attempt another repair?
Yeah, basically. Because I wouldn't want to sit there, and I've had this circumstance where you're sitting here trying to figure out, why can't I get this fistula to make any progress? And it turns out you're actually dealing, even in the setting like an isolated perianal Crohn's.
Mm-hmm. Some additional questions about fistula management. A couple of frustrating OR scenarios that we have all encountered. What do you do if you have a clear external opening, and then when you attempt to pass your fistula probe, scenario number 1, the probe seems to travel up beside the rectum and it's not turning into the anal canal, you're unclear where the internal opening is?
Okay, so I kind of going along with the second line too of this whole idea that it's not quite budging into the mucosa. I really like to use dilute hydrogen peroxide if I can't find my internal opening. I am not going to create an internal opening if it does not naturally pass. I would much rather play something like a 12 French or a 10 French mushroom drain if I need to get control of the sepsis, let things calm down, and work on getting something like an MRI, a perineal MRI. But if I can inject a dilute hydrogen peroxide with something like a Hill-Ferguson or a proctoscope or like an anoscope in the anal canal and actually see where it's coming out, at least then I know I have an internal opening. The other situation that can be very frustrating similarly is kind of, it's like a suprasphincteric or an extra sphincteric tract. So it does the up and over. And if I know I have an internal opening, but it's kind of doing up and over this kind of a move, I've actually used the magnetic bridle tip and a tonsil, and you can get the magnetic bridle tip to marry, and you can pull it through and use the bridling silastic string as your seton.
I'm gonna try that. That's a great tip.
Oh, it's awesome. It's so satisfying.
Yeah, sometimes
Nothing
you need
sterile,
something more
doesn't matter.
flexible. Sometimes you need something more flexible to navigate those up and over tracks.
Yeah,
Are
exactly.
you routinely obtaining MRI for any complex fistula?
Complex, yes. But complex is kind of a challenging thing to define, right? So if I really can't delineate the anatomy, or if I'm concerned there's a secondary tract, or similar to, my concern there's an underlying Crohn's pathology, those would be circumstances where I would get an MRI, and I'll specifically order an MRI perineal protocol, which is a little bit more specific in terms of how it delineates the soft tissue.
We have a couple questions about the use of PO antibiotics, both post-hemorrhoidectomy and then also post-drainage of a perianal abscess to reduce the risk of fistula formation. Thoughts on that?
I guess I'll answer the one about post-hemorrhoidectomy PO antibiotics. I had a few staff that used it in my training to reduce pain. I personally do not, because from the last time I reviewed the data, it was not sufficient data to support it. But I do know a few people who use it. So I guess that probably is based on anecdotal experience.
And then how about after drainage of an abscess?
So if, like I said before, if I have concern about an underlying risk factor, so immunosuppression, diabetes, cellulitis, etc., then I will. I don't use it to reduce the risk of fistula. I might use it to settle down inflammation in anticipation of an EUA where I'm trying to find a fistula tract. That's probably voodoo, but I've definitely done that where like they come into my clinic, I'm getting them into the operating room in the next week, but there's kind of some residual inflammatory process going on. So I've tried to settle it down before. That's again, not data driven at all. I don't know if either of you guys, do you use it to reduce risk of fistula?
No, same. It's dictated by patient risk factors,
Yeah.
immunosuppression, and then if they have associated cellulitis, then yes.
Yeah. I feel like I've used it a few times with some Crohn's patient. And again, it's some of it was not really based on a specific selection criteria. So other than those patients you mentioned, diabetes, immunocompromised, I've done a few Crohn's patient and try to reduce fistula formation, but I honestly can't remember why I used it in those cases.
You could make the argument for the anti-inflammatory process in terms of like ciproinflagellar. Think about like pouchitis, you could maybe make that kind of argument.
Yeah.
With regard to mucosal advancement flap technique, are you incorporating sphincter muscle into that flap?
So not into the flap. I try to typically do so like if I'm along the anal canal, it's technically like if I'm along the sphincter complex, I'm just doing a partial thickness. I'm leaving my entire sphincter complex where it is. And I use the sphincter itself to kind of recreate when I'm closing the internal opening, I'm putting the figure of 8 in the actual sphincter. So that's kind of where I'm recreating my scaffold. If I'm doing something up higher or I'm doing an anterior or an rectovaginal, I'm going to try to do as much full thickness as I can. So it's kind of like once I pop over the sphincter complex, then like the muscular layer is incorporated. And the only other time I'm taking bites in the sphincter complex is if I'm trying to decrease my potential space because I don't want like a seroma or a hematoma to form. So I might, if I'm laying down a larger flap, I might take a bite of the underlying tissue. I typically do vertical mattress. And so when I'm doing my underbite, I'll grab a little bit of my underlying tissue.
So the flap itself is mucosal. You're not taking any underlying muscular tissue with that.
If I'm in the sphincter complex. Does that kind of make sense? Like I'll leave my sphincter and then I'll pop deep once I go above it.
Okay. We have a question about management of mucosal prolapse in elderly patients. A little outside the scope of what we discussed today, but I know the THD, hemorrhoidopexy technique can be modified to basically you set your pexy point just a little bit higher and you're trying to draw up that prolapsing mucosa. I tell them this is going to recur, like 100% certainty. We're just trying to buy some time with this. And you also have to counsel them that there's going to be pain associated with that for sure, because you're basically doing the most aggressive form of mucosopexy. Anyone else comments on that?
I guess my only other comment would be just doing a full workup, or like at least a clinical exam, make sure it's not rectal prolapse, no evidence of pelvic floor dysfunction, deception. But if they elderly and don't have symptoms from it, maybe we should leave it alone. I don't know.
Yeah.
But yes.
I have like, if they kind of have like a partial, like I was just thinking about one on Monday, I did this on Monday. She had this like one lip of prolapsing mucosa that was so chronically prolapsed. It was, bleeding and had mucus drainage. And so I excised it almost like an internal hemorrhoidectomy, which I know is a little bit made up. But it was like this just kind of like a longitudinal resection just to kind of get rid of the actual symptomatic portion. And in all reality, I will be back there probably with another segment of it doing the exact same thing in 6 months. But for now, it took care of the problem.
Great. And thanks everyone for being so interactive in the comments. Like we may not even get to cases if we're just going through questions, and that's fine. The whole purpose of this is to have a forum for discussion of, these are difficult for how commonly we see them. These are challenging problems to manage. So we have a question about management of anorectal pathology in the setting of IBD for example, somebody with known IBD comes in, but it looks like it's their internal hemorrhoids that are bleeding, and can you perform rubber band ligation? Does it matter if there's proctitis or not? Kind of what is your approach to that? And I think probably this applies more to hemorrhoids specifically, because obviously fistulas, I think you're going to do a less is more approach with CTON and kind of touch base with their GI provider about their medical management.
Yeah,
Open
so
that up.
I would say for this is I have the similar approach with the fistula as well, which is that you need to get control of the underlying problem here. Obviously, the underlying problem is a little different than the usual problem with the bathroom and straining. This is chronic inflammation, so I think telling patient that needs to be addressed is very important. Because the reason those hemorrhoids are flared up is because they have a flare up of their Crohn, so we gotta get that medically managed. But sometimes when they have active issues, you know, like bleeding, at the time, in addition to conservative management, can consider banding if there's no proctitis. So would I band a Crohn's patient who doesn't have proctitis? Yes. If they have proctitis, I am a little too scared to do that. I don't know if any of you have done that in that situation, like banding. Yeah, I usually would just kind of focus on the Crohn's
I
management.
agree 100%. Like active proctitis is a big, we got to get that managed before we embark on any anorectal procedures. And even if they do have pretty well controlled disease, like you don't have proctitis on exam, I'm very leery about like excisional treatment for hemorrhoids. I don't know what your feelings are, but I've tried to pitch, for example, THD for those patients, and my thought process is I'm not creating a wound. This is a little, you know, if it's something that I think is a little more than what hemorrhoid banding is able to manage, that would kind of be my next go-to. And counseling, this may not be perfect, but we're, you know, your situation is unique, and we're trying to balance the risk and benefit of, you know, an intervention to help your hemorrhoids with not causing a worse problem because of your underlying Crohn's.
And then I'll also add in, so kind of as like my general spiel for my hemorrhoid patients, it's like the hemorrhoids aren't the problem. The hemorrhoids are a consequence of a problem. Typically, right. And you may have the residual, like just super redundant internal or external tissue, which you can eventually address. But if we're dealing with like someone who's had an ileocecal and maybe they have some like malabsorption of bile, so trialing and talking with GI, do we need to try to initiate like a cholesterol or a fiber? Like, what can we do? Do their hemorrhoids seem to be exacerbated because they have chronic multiple bowel movements a day, or actually do they have more of a constipation variant of Crohn's? So like, what can we do to try to treat whatever may be igniting them? Like, I am extraordinarily leery of touching anal canal tissue in a Crohn's patient, just because you never know when it's going to go wrong. And I don't want to leave them with a worse off situation.
Agree.
There's a question about the difference in efficacy, cost, and availability of the two HPV vaccines, and I apologize, I don't know the answer to that. So I just know the quadrivalent is kind of what we have easier access to here. The next question is, oh, go ahead.
One thing I was going to comment on, based on what your comment before about utilizing HPV vaccination in the cervical dysplasia population, though we don't currently have recommendations, the general consensus is that we do promote HPV vaccination within the anal dysplasia population, particularly in the high-risk HPV population, with the idea that your body could actually, in theory, you can clear the virus. And so we will see conversion from high-risk HPV on PAP to no longer being positive in the setting, either just with immunocompetent patient, or especially in the immunocompromised population with vaccine introduction. And if I can add one other thing about HPV, because I think this is to go off of Dr. Band's point about reassuring patients that this isn't a sexually transmitted disease. They've done studies. So in a lot of Latin American populations, they actually teach young women to wipe from back to front, as opposed to from front to back. And what's really interesting, that within these patient populations, they've noticed significantly lower rates of anal dysplasia and HPV variant anal dysplasia. So this goes along with the whole idea that this is not a sexually transmitted or like some question of infidelity, but rather this is a pattern of behavior because it's a skin-to-skin contact. So the virus, we have easy exposure throughout our entire lives because so many of us carry it, and it can be something as simple as a wiping that can actually expose you and put you at risk of something like an anal dysplasia, because there's a lot of stigma. I found, especially in my young female population, that I'm struggling with kind of counseling them through it.
That's a great point, Dr. Cantors, because patients will ask. They'll say, I've never engaged in anoreceptive intercourse. How did this happen?
Right.
Yep. All right. Any experience or opinion about the application of laser, whether for fistulas or for hemorrhoids? I do not have any prior experience or opinion on that.
Agree.
Do I?
Hemorrhoid with a firm base. If you're worried about malignancy, approach to biopsy. I would say if you're worried about bleeding in a clinic setting, exam under anesthesia. Or if you're more worried, if it's an internal lesion and you're more worried about like an adenocarcinoma as opposed to a squamous cell, or regardless, if they need a colonoscopy, you can try to combine colonoscopy with an exam under anesthesia in the operating room. You just want to ensure you have access to some additional tools for safe hemostasis in that location. Management of prolapsing hemorrhoids in a patient who already has incontinence. Are we going to fix the incontinence by treating the prolapsing hemorrhoid? Or are we going to make it worse?
Probably
Exactly.
Yeah. Yeah, that's a discussion you have to have with the patient, right? Because hemorrhoid does contribute some baseline anal pressure to help with your continence. So you have to have that discussion. Is it propping open your sphincter and causing incontinence, or is it you're going to take it away and then make your incontinence worse? So I usually have that conversation with patients. I do think that if the incontinence is not fixed with, for example, a THD, then you have to do a workup like normal for incontinence and do your pelvic testing and go through the treatment of that. That would be my.
And just making sure you also don't just have prolapse, like mucosal or full thickness prolapse, because not uncommon that they come in with hemorrhoids and it's actually tissue prolapse.
Yep. Very good point.
Yeah, these are all great points. Even on your office exam, if they're giving you incontinence as part of their symptoms, ensure that you do during your rectal exam an assessment of their sphincter and pelvic floor strength and coordination. So coach them to squeeze, coach them to Valsalva. That's going to give you at least an initial sense of, do they have really, really weak resting tone at baseline? Patulous anus on your visual exam is a huge red flag that this is actually rectal prolapse or kind of more than that. And yeah, agree with everything everyone else said. All right, we have questions about anterior fistulas in the male patient population, and does that impact your approach?
So in that situation, I mean, that makes me more anxious about the possibility of something like a Crohn's pathology or maybe a misdiagnosed hydradenitis, something that isn't actually an anal, because that's another thing that we'll see pop up. Someone comes in with an anal fistula and it's actually hydradenitis. So trying to full examination. If I have any suspicion, I check their axilla as well, and I'll check their groins and make sure that's not what we're dealing with. And extraluminal Crohn's would be another concern, like a true perianal disease. If I feel quite confident that this is an anterior fistula in a male is very rare, I'll also add. But if I really feel confident this is more cryptoglandular and there's some weird sort of extension towards the penile shaft, I don't think I've ever seen it outside of Crohn's, I would do something like a partial fistulotomy, basically curette down my tract, try to get myself to a true just perianal fistula as opposed to a perineal fistula, and clean up, debride the area, etc.
That might
I'd be
be a
very
nice scenario
suspicious.
to get a CTON in and get an MRI and
Yeah.
just ensure that you're not missing something atypical.
Yeah.
Approach to treatment of fistula with associated fissure. Are you doing limited sphincterotomy? Are you doing Botox after fistulotomy? Preferred approach there.
How to treat the fissure. start with that and deal with the fistula later. They're usually pretty superficial and they're going to be distal to the sphincter complex. So though there may be some sort of drainage, it's more likely coming from like the fissure area than it is actually from a fistula. I don't know about you. I'm curious what you guys do. I do a lot of Botox, much more than sphincterotomies. And I think that's because we're millennial colorectal surgeons. And also I'm curious, I'm a 100 unit person. I'm a 100 unit and 2 cc's. What do you guys do?
I do the same, 100 unit, 2 cc's, 0.5
Yeah.
each quadrant.
100 units, and I agree. I do a ton of Botox, and we also probably have a bias because this is the opposite of a mantle. We have all
Yes.
female providers, so we're seeing a disproportionately female population.
True.
And my paranoia about incontinence in a young female who comes in with a fissure is real, and so I am much more likely to do Botox first. I pitch it as, worst case, it's a dry run for would we have any incontinence issues if we proceeded with sphincterotomy. It is so rare, the patients who come back and ultimately need sphincterotomy. And so, yeah, if it's a very superficial, tiny fistula, I think that's dealer's choice if you want to just do fistulotomy of that versus not, but definitely treating the fissure has to be part of your treatment plan.
And also pelvic floor PT. I feel, and again, your point about the disproportionate patient, like our patient population is typically going to be a more female population. And I feel like probably at least a third of my patients who come into my clinic for one reason or another end up with a pelvic physical therapy referral. And when I do a digital rectal exam, I don't care why I'm testing you. I'm going to check your pelvic floor because this is probably, and I ask about dyspareunia, I ask about urinary retention, I ask about all of these things in my hemorrhoid patients, my fissure patients, all of them, because these are things people don't typically bring up. And then all of a sudden you realize you're actually dealing with this like whole other process.
Yeah, I think it's massively underdiagnosed for a lot of common anorectal pathology, hemorrhoids, fissures, and you can usually tell on exam, like, I know why you have this. You have terrible pelvic floor dysfunction, and your muscles aren't relaxing. So
exactly.
All right. There's a question about hemorrhoid procedure with IR. I apologize. I'm not sure what that refers to. You can put additional. Oh, it's from Dr. Rosen. Feel free to put additional info in the chat box about that.
So we just sort of side hustle.
There's a question about Botox use for mucosal prolapse. I have not. I only use Botox in the setting of spastic, underlying muscle, which I feel is usually not the case for mucosal prolapse. And then questions about how long will you insist on conservative management before coming back to some sort of procedural intervention?
Conservative management for what?
I'm guessing
I would say for hemorrhoids or for fissure.
Yeah, I usually see patient backs about 4 to 6 weeks, depending on how much they need to work on, how much stuff they need to work on. So if they're not doing any fiber, if they're straining, if they're spending too long on the toilet, all of the check marks, I usually see them closer to 6 weeks. Whereas if they are already doing some of it and I just kind of wanted to follow up and see if things are getting better, then 4 weeks.
Oh, and I'm going to put a plug in for the squatty potty. That's another, like my dot phrase for hemorrhoids. It's like fiber, 64 ounces of water, squatty potty, no phone on the toilet, limiting toilet time to less than 5 minutes. And those are like my 5 things I always tell them. And with fiber, I say start low, go slow. Half a teaspoon a day for a week, 1 teaspoon a day for a week, 1.5 for a week. Don't go hog wild because then they'll never be compliant.
Yeah. And then the other thing I forgot to mention for fiber is patients usually say, oh, I eat a lot of fiber, I eat fruits and vegetables. I tell them, even if you eat fiber, you usually don't get adequate amount. And I even give them a little table so they can keep track. But I tell them you need to do supplements and then start to get into the supplements. But that is another thing that come up quite frequently is that, oh, I eat a lot of fiber.
Well, I just want to say thank you to everyone and thank you to all of our participants for making this so interactive. We are at the end of our allotted time. We didn't even get into the cases. I know Rita is going to send out the slides from the presentation today, and if you want to peruse the cases in the notes section, there were prompts for some points of discussion, and feel welcome to use that in your own institutions for kind of discussion or learning purposes. And then join us for our upcoming program. The next topic is GI motility disorders. And thank you again. This was a great session. I think it's always better to answer questions from our participants rather than just lecture you. So thank you so much. And we look forward to our next session. Have a good night, everyone.